I have some slides showing that will go over some kind of just general kind of background to help us get us prepped for the case, and then we'll get into the case in a few minutes. But let me know if the slides don't start moving or anything. So the idea here is we're going to talk about a patient in a few minutes that had a multi-gene test and had some implications for phenoconversion. Maybe I guess we'll keep some faux suspense, and how we can apply that to pain management. So before we dive in, I do want to note that I do have one potential conflict of interest in that a laboratory shown here did fund a clinical trial that I designed, and they provided financial support to my institution to help execute that trial. And so what we're going to be talking about largely is about this relationship and this biological mechanism right here. And so when you talk about pharmacogenetics and opioids, I like to focus on tramadol because tramadol is so widely prescribed. It's the second most commonly prescribed opioid in the country. It used to be the 25th most commonly prescribed drug in the country, and now I think it's down to number 35. So it's gone down a little bit, and it's only behind hydrocodone in terms of prescribing rates for opioids. And so when we talk about pharmacogenetics, it's widely prescribed drug, and it has a high level of evidence for a pharmacogenetic relationship. And as you all may already know, tramadol itself is a prodrug, and while the tramadol compound does have some serotonergic and noradrenergic activity that might have a role in pain response, it is thought that most, if not all, of the analgesic activity does come from the active metabolite O-desmethyltramadol, which has a 200-fold higher affinity for the opioid receptor. And the gateway to that active metabolite is, of course, CYP2D6. That's what gets us there. And as we all know, CYP2D6 is variable. We have a genetic variability in the gene that encodes the enzyme of the same name. I'm not going to go through this table in detail, but just to make sure we're on the same page, we have these 4 different phenotype classifications per CPIC, or the Clinical Pharmacogenetics Implementation Consortium. And patients can have a variety of phenotypes, from having more activity than normal, what we call ultra-rapid metabolism, to having little to no enzyme function, what we call poor metabolism, or having some activity but not as much as normal, in other words, intermediate metabolism, and then, of course, normal metabolism. The one thing I want to call out on this slide in particular is also note another way to describe this kind of this gene and then the enzyme's activity is through this concept of an activity score. And this is where we take CPIC is assigned actually quantified numbers to the allele function. So, for example, a star 1 allele is a normal function allele. It has an activity score of 1, and a star 4 allele has an activity score of 0. It's a no function allele. And so that patient's total activity score would be a 1 because you just add them together. So 1 plus 0 would lead us to 1, and we classify them to an intermediate metabolizer. And so that extra level of detail, we'll get into why that plays a role for some patients in particular here. But before we get into that detail, let's first focus on kind of the clinical implications here of how this information can be used. CPIC guidelines are available for opioids. These were recently updated in the last couple of years. And the gist of them is basically if a patient has poor or ultra-rapid metabolizer status, they recommend avoiding tramadol or codeine use due to the risk of ineffectiveness for poor metabolizers and a risk of toxicity for ultra-rapid metabolizers. And keep in mind, these are it's a prodrug. Both of these drugs are prodrugs, and so more active metabolite occurs from that ultra-rapid metabolism, and therefore the risk of toxicity. But that toxicity risk is thought to be highest, particularly in pediatric patients, especially if people have additional concomitant risks for respiratory suppression, like sleep apnea and other conditions like that. And the guidelines do touch on other genes, other drugs, but long story short, there are no other recommendations to change a pharmacotherapy decision for any other gene or any other drug besides codeine and tramadol. Now, we talk a lot about genetics, right? And how a gene might influence an enzyme's function in a drug's metabolic pathway or any kind of pharmacotherapy. But we also need to keep in mind drug-drug interactions and this concept that we'll introduce in a moment called phenoconversion. As pharmacists, we're really familiar with looking at drug-drug interactions, and this is something that I imagine we were all thinking about prior to even hearing about pharmacogenomics throughout our training, was this concept, because it's kind of the backbone of what we do. And so also you might know that there's not really a set source of who to go to for drug-drug interactions. There's a lot of variability when you go to different tertiary resources, and it can be a bit of a challenge. And so that's certainly a theme here in this concept of phenoconversion. But the source that I've picked to use for this case, and what I generally use in my practice, is from the FDA. We can see the FDA lists a few drugs as clinical index inhibitors for CYP2D6. So in other words, these were the standard drugs that if you were designing a study and you needed a drug to have a certain amount of inhibition against that CYP2D6 enzyme, these are kind of the standard that the FDA advised the pharmaceutical industry on. Now, there has been a little bit of an update where most of these are now considered clinical inhibitors and no longer index inhibitors. It's probably a level of detail that we don't need to get into today. But the most important point is that these inhibitors have different strengths of inhibition. So we have strong inhibitors or inhibitors that increase the substrate, the AUC of that substrate by 5-fold or more. Moderate inhibitors, which is somewhere between 2 and 5-fold, and then weak inhibitors, which is 1.25 to 2-fold. And by and large, weak inhibitors, I typically don't consider those in clinical practice unless the drug has a narrow therapeutic index. It's just kind of my personal preference and what I've seen others do as well. And so I've put in bold a few drugs that I think are most important for the chronic pain population where we're thinking about using opioids, because antidepressants, like the 3 drugs shown in the strong inhibitor row, these are drugs that are more commonly used in a chronic pain population because patients with chronic pain are more likely to have depression and be on one of these medications. And so it's really notable that these also happen to be strong inhibitors. And duloxetine is a moderate inhibitor, but it's a particularly kind of insidious one because it's also first line for treating neuropathic pain. So you can easily see a situation where a provider might be adding duloxetine to tramadol to help treat a patient's neuropathic pain. Maybe it's a multimodal etiology for that pain for the patient. And so they might be inadvertently kind of reducing the effectiveness of that tramadol. So I've mentioned phenoconversion a little bit, but let's talk about how to actually put that together. And so this is, I would say, an area that is growing and needs a lot more growth. The concept of phenoconversion and how to actually put this into practice, we have a method that I'll walk through here, but I want to be very clear that this is not a rigorously studied methodology to try and compare, one version of doing phenoconversion to another and trying to figure out which is better. And so this is a version that we have, a version that I've used in my practice and then also in some studies as well. So we'll walk through that. But anyone interested in research, this is a very interesting area to design some research questions to see if we can get better systems, because maybe we can do better. But with that said, the first step is we start with the CPIC phenotype. And more specifically, I look at that activity score. And so we kind of start with that, use CPIC's wonderful resources. Then from there, I use that FDA table to assess, are they prescribed a CYP2D6 inhibitor? And if it's a strong inhibitor like paroxetine, bupropion, and fluoxetine, it's pretty simple. You just change them to a poor metabolizer. For moderate inhibitors, it can be a little more complex, but it got a little simpler once recently the CYP2D6 phenotype definitions changed a few years ago to where an activity score of 1 used to be called a normal metabolizer, but now we call that an intermediate metabolizer based on a CPIC update. And so now that activity score, basically you cut it in half, but really it usually just means the patient is an intermediate metabolizer as the most common thing that comes out. Then we assign that phenotype per the CPIC guidelines in their thresholds, and then provide the therapeutic recommendations per CPIC. So to actually take this kind of concept and apply it to practice, I just want to show a couple of examples before we get into the case. One is a prospective cluster design trial that I worked on a few years ago when I was at the University of Florida training. And this was a design where we basically pragmatic is the key word. We had adults with chronic pain who are either receiving or eligible to receive an opioid. And we did not have any additional criteria around, how severe their pain was, pain etiology, anything like that. Really what we want to do is see if we dropped pharmacogenomic testing into some clinics, didn't do it at others, is there a difference? And so everyone kind of started out the same, where we did a buccal swab or cheek swab. That's what we used for the genotyping. And then asked some questions, shown here as Choir, where we asked a lot of questions, but the main one was pain intensity. That was our primary outcome, was to see if pain intensity was different between baseline and 3 months later. And in the control arm, we did that stuff and we just kind of sat back and let the doc do their thing. And 3 months later, we asked the patient, hey, remember that sample you gave us? Do you want us to process it and give you genetic test results? 99% of those patients did agree to that. And then we asked them those questionnaires again. In the implementation arm, it was really the same thing, but we also then added the genetic testing, which we just looked at CYP2D6 alone. And then we had a pharmacist consult. And so this pharmacist consult note took into account not only CYP2D6 genotype, but also phenoconversion in the process I just described in kind of combining CYP2D6 inhibitors and activity scores. And so that's what we did in this study. And this was a few years ago, and we made recommendations for alternative therapy for both poor and intermediate metabolizers. And in the group that we hypothesized to benefit, which is poor and intermediate metabolizers prescribed tramadol or codeine, we did see a statistically significant benefit, as shown by the lower the bars get, the more the pain improves. That was in the CYP2D6 guided arm. That was a more significant improvement compared to the usual prescribing arm for this group that we hypothesized to benefit. So that was great. Good news. Primary outcome was successful. We also looked at but you look at that bar and you're like, well, what does this mean to a person? Is this a clinically meaningful amount of improvement? And so we also looked at a threshold of at least a 30% improvement in pain intensity, which is a threshold set in the literature as a clinically significant amount. We found that 24% of these patients in the CYP2D6 guided group met that threshold, compared to 0% in usual care. 24%, ideally that number would be 100%, right? But I think there may be some things we could do better in the trial to get that number higher. But also, chronic pain is very difficult to treat. Pharmacotherapy is not the only answer. And it's going to be very hard to get to that 100% marker. But I don't think we should lose sight of the fact that not a single person in the usual care arm who's intermediate or poor metabolizer took a tramadol or codeine and had a clinically meaningful improvement. And the last kind of thing I'm going to introduce before we transition to the case is a trial that we just completed, and our analysis is ongoing. This is actually where our case comes from. It was a patient enrolled in this trial where we randomized around 250 patients. These were all adults treated at a primary care clinic with pain for at least 3 months. A little different from the last trial, that all of these patients had a current prescription for either tramadol, hydrocodone, or codeine. And then it was a randomized trial. The main thing that we want to focus on for this case is that it was an 8-gene panel test, CYP2D6, of course, but we also had other genes that were examined, 7 of which had CPIC guidelines. And we provided PharmD consult notes. So our intervention here is a consult note that we put in the chart. We do take into account phenoconversion and assess for drug-drug interactions, particularly as it relates to pharmacogenetics. And then we put that note in the chart, tag the doctor, and hope they follow our recommendations and try to make it look like, try and make it fit into routine clinical care. Pharmacists don't prescribe drugs, so we want to, at least outside of places like the VA. And so we wanted to try to make this look like real world. And we also get patients through this mechanism where it's an e-consult service where docs place an order in the EHR for a pharmacogenetics consult. The patient comes to us. Most often it includes almost every time includes a patient, a call to that patient to explain the patient, the benefits, limitations, et cetera, of pharmacogenetic testing. Sometimes these are for patients for pain, and then we facilitate testing and then upload a consult note when those results come back, and it kind of follows that same process. So with that, I'll pause here and turn it over to Alyssa.